Hello. Hi, this is Dr. Scott Hutchison here in Tucson at Reproductive Health Center. And this is Hutchison's Huddle. And tonight we're going to talk about genetics and genetic testing. And we're trying to use social media for good through patient education. And with me is Dr. Aleena Lakhanpal, who is a great general OBGYN down at Banner, UMC. And Dr. Lakhanpal is, she did her undergrad at the Johns Hopkins University in Baltimore and then returned to her home grounds of Georgia to go to medical school at the Medical College of Georgia, and then came here for residency training in OBGYN at the University of Arizona. And she's fantastic, and later on we'll put on her contact info if you need an awesome general OBGYN. So hello, Dr. Lakhanpal.
Hey, Dr. Hutchison, how are you?
I'm awesome.
Good.
How are you tonight?
Glad you got this up and running.
Yeah.
The introduction, what can I say? I just love traveling around the United States. It's my goal to live in every single region of the U.S., right?
Well, you can. So anyway, we're going to talk a little bit about genetic. I thought first, why don't we just talk about genes, just for basic stuff, just start from the very basics about what are genes and how do they influence our health?
Well, so that's, seemingly a basic question, but as you know better than probably anyone, there's a lot that goes into genes. It's not just the genes that our mom and dad gave us. It's also how the environment has affected our genes and how different viruses can affect our genes and various things. But basically, starting from the beginning, we get DNA, half is from our mom, half is from our dad. And as like I said, you know better than anyone, the sperm meets the egg, they combine genes, and then, we get a total of 46 chromosomes, and with the X and the Y kind of determining, or definitely determining your sex and maybe determining your gender. That's probably a topic for another day. But as we know, there are different proteins that can affect how those genes are phenotypically manifested, which is to say how they're physically manifested, and that kind of contributes to who we are. So, your mom could have blue eyes, your dad could have brown eyes, and you can end up having green eyes. So there's a lot that goes into how genes are passed down.
Right. So you said you get one like one chromosome from your mom, one from your dad. What happens if you don't get one of them, or you get too many of them of the same type of chromosome?
Well, so that's when we start wandering into territory that requires genetic testing. So essentially, one of the most common things that you'll see or hear about is when you get too many chromosomes from chromosome 21. That's called trisomy 21. As we all know, Down syndrome. There's been a lot actually in the media these days about Down syndrome. There have been a lot of different clothing companies, including Tommy Hilfiger, have hired Down syndrome models and things like that. So there's a lot right now in the media about Down syndrome. So I'm glad that you asked the question. Down syndrome and other triploides or aneuploidies, which is to say when you get an abnormal number of chromosomes, can be manifested in a lot of different ways. Down syndrome is the most widely recognized, and that can be from a couple of different things. So the most common way to get it is meiotic non-disjunction, where you end up getting 3 of those chromosomes. Now, the 21st chromosome is actually the smallest chromosome in our genotype. So we can live having 3 of those. There are other chromosomes like 13 and 18, which if you get 3 of those, might not be compatible with life. However, because that chromosome 21 is real tiny, we can actually live having 3 of them. Now, as we see in our everyday lives, in the media, everywhere, Down syndrome can be manifested or show up in different ways. There's a sort of standard phenotype that people see with the wide set eyes. They can have different creases in their hands, and it's something that aside from looking a certain way, they can have some inner issues as well. So, for example, one of the most common issues is a large ventricular septal defect in the heart, and that's something that might have to be fixed very early on in life. They can have issues with the aorta. They can have issues with their stomach. A very common issue is duodenal atresia. So that's basically where in the intestine we get a little stricture, and so everything proximal to that intestine gets really dilated. And that can be a significant issue. So these are some of the things that we worry about when our moms are pregnant, especially older moms. Like I had alluded to earlier, one of the most common ways of getting Down syndrome is a meiotic non-disjunction. So those chromosomes aren't separating normally. And so that's how you end up getting 3 copies. As moms get older, their eggs don't divide as normally after fertilization, and so that increases the risk of having a baby with something like Down syndrome.
Yeah. So you said, a lot of those were not compatible with life. So what goes on there? I mean, are they just not implanting, or do they miscarry, or what's the deal?
So most of the times, 2/3 actually of spontaneous abortions or miscarriages will actually have, if you look at the DNA, will have some kind of chromosomal defect. And actually 3 out of every 100 live births has some kind of chromosomal abnormality, believe it or not. But what it means to be not compatible with life is most of the time they will miscarry, but there are cases where you can carry to term and they can live for a short while, but without all the nourishment and protection of the uterus and the placenta and everything that mom can give them, they can't live for very long on their own.
Yeah. So the other kinds of genetic diseases can be just smaller pieces of DNA, right? Smaller, like little gene defects.
Right, exactly.
So talk a little bit about autosomal recessive gene disorders and kind of what some of those are like.
Perfect. So autosomal recessive disorders basically means that a mom could have a bad gene and a dad could have a bad gene. And they wouldn't know that they had this bad gene because autosomal recessive means that they have another good gene that makes up for it. So another good gene is basically suppressing that bad gene. A very common instance is cystic fibrosis. That is an autosomal recessive disease. So in the Caucasian, French Canadian, Ashkenazi Jewish populations, especially, cystic fibrosis is common. And that's because you're getting 2 of those bad genes. And so when you get 2 of those bad genes or recessive genes, then the disease can show up. And so then they can have lung issues, pancreatic issues, things like that. And that's just one example of an autosomal recessive disorder. But essentially, people can go around carrying one of those recessive genes their whole life and never know until they meet someone else with that recessive gene and decide to procreate. And then that's when it shows up.
Yeah. So I think it's interesting why some of these diseases or why they're thought to have gotten started in certain populations. Can you kind of address that?
Well, that kind of has to do with people. People
like the benefits of, like, if you're a carrier for CF, what's the deal there?
So if you're a carrier for CF, then you definitely want to find someone who might not be a carrier for CF.
But what's the good part? What's the good part about being?
The good part is they can come see someone like you. Let's say I had a recessive gene for CF and I fell in love with someone who had a recessive gene for CF, and we didn't want that 25 to 50% chance of having a kid with CF. So we could come see you and we can get something called pre-implantation.
Yeah, but I mean but the cholera thing. Do you remember the whole cholera thing with CF? Why it's thought that those populations were.
I don't know about cholera, but I know about malaria and G6PD deficiency and sickle cell.
Right. So G6PD, what's the good part about having G6PD deficiency? I don't know.
There are a few good parts because there are a lot of antibiotics you can't take. But one good thing is in the sub-Saharan African and Middle Eastern populations, G6PD deficiency actually alters your red blood cells in a way that you don't get, or you're less likely to get infected with malaria. And it's the same thing with sickle cell, which is, both of these are actually autosomal recessive disorders. And so because you have these altered red blood cells, you're less likely to be infected with malaria, which is common in those areas. So it's interesting how these, what we know as disorders, have actually come up and can be protective in certain situations.
Right. Yeah. So like the CF and cholera, and you know, if you think about Europe, if you think about ghettoization of like the Jewish diaspora into Europe, into these little dank villages that were cold, and you know, everybody was all huddled together inside, you know, then you know, clean water gets to be an issue. Same with tuberculosis, with Tay-Sachs disease. Apparently Tay-Sachs carriers are resistant to tuberculosis to a degree. So
that's interesting.
Similar kind of a gig. Yeah. So so anyway, so you touched on being able to test ahead of time. So you find out you're a carrier for one of these things through one of these panels. And are you guys using a specific panel like Council, or what are you offering?
We're using the Panorama panel.
Panorama. Okay. And how many things does that test for, ballpark?
So I actually don't remember off the top of my head. And one of the things about a lot of these panels is that you have the option of doing what's called a limited panel or an ethnic specific panel. So for example, my husband is Jewish, and if he had decided to do one of these panels, it would test for things that are a little bit more specific in the Jewish population, including Tay-Sachs and cystic fibrosis, Canavan's disease, other things like that. Now, there's also options for pan-ethnic testing, which kind of tests for everything. And that's actually something that's pretty interesting, because sickle cell, for example, is more common, or thought to be more common in the African-American population. However, there's a recent study in California that looked at over 20,000 babies and saw that we're missing actually like 24% of hemoglobinopathies because we're testing specifically African Americans. But in this day where, you know, people, like I said, my husband's Jewish, I'm Indian, there's a lot of interracial marriage, and people don't necessarily know their ethnic background. Not everyone is jumping up to do a 23andMe. And so we could be missing some of these. So that's how this pan-ethnic panel came about. Yeah,
it's interesting. Boy, we've got some patients who do not fit the demographic profile, but they certainly have this bad disease, and a lot of them have already had a child or two who's gotten the disease, sometimes with pretty bad results. So they really would like to not have another affected. So embryo testing, you know, so if you find out somebody has one of these things or two of these things, and actually I always tell people now, if they do an expanded panel, I say, hey, look, you know, you're probably about 40-50% likely to be a carrier for some weird disease. Yeah. So just don't freak out about it. But then you got to have the other partner screen so your weird diseases don't match up.
Right.
But if they do, then so we do embryo testing. And we do that by growing the embryos to about the 200 cell stage. You know that, you saw that. And then we make a little incision in the embryo, take out a few cells, and then those from what are going to be the placenta, and then those go off to the laboratory for testing, and we get results back in about 2 weeks. Like you said, on average, if you have a couple where they're both carriers, about 25% of the embryos are going to be completely affected. I mean, they're going to have both bad copies. But then, you know, the carriers are fine to transfer, and the non-affecteds are fine to transfer. So most of the time, we've got something to transfer. Yeah.
And this is where we're talking in an ideal situation where people are coming in for preconception counseling, which is actually recommended by ACOG and recommended by most OBGYNs. Now, a lot of people come in already pregnant, and then they're wanting to do the carrier screening, and that can change things. So in an ideal situation, we're having people come in prior to conception and meeting us for a preconception visit. And this isn't just for carrier testing and genetic testing, it's also testing things to see if they are still immune to rubella, still immune to chickenpox, things that we can vaccinate for prior to pregnancy, but not during pregnancy. But so in an ideal world, preconception testing, people are offered carrier screening because then that gives us a chance to screen the partner, see if they're both carriers, and if they are, send them to someone like you.
Yeah. I think cystic fibrosis screening got really big about 15 years ago. So we started offering it to pretty much everybody. Mm-hmm. And the deal with, CF, it's such a horrible disease that a lot of people were pretty on board with going ahead and doing it. Now that there's all these other diseases to screen for, I think sometimes I'll get pushback from patients and they'll be like, man, this is like playing God. This is like finding out way too much information and I don't want to do it. Right. And then talk about CRISPR, because some of these diseases are going to be edited out of existence probably.
Right. Yeah. And I mean, is that for better or for worse? We're hoping that it's for the better, but so briefly, CRISPR is basically a way of editing genes. It's removing the bad alleles, which are sort of variants of genes, to be able to produce an optimal gene.
Right. And so it was found in these bacteria. I think it's really cool. And these scientists were like, whoa, there are and it's called CRISPR for clustered.
Oh gosh. Maybe back to undergrad now.
Clustered reoccurring palindrome sequences or whatever.
Yes,
so they found those like these are weird, and then they were associated with some viral DNA, and so this one researcher was like, "Whoa, this is probably a bacterial defense mechanism against these viruses to be able to cut out the viral DNA when it gets in there." Interestingly, then that was one of the first commercial applications was putting it into making yogurt bacteria made to culture yogurt resistant to viruses.
Really?
So because sometimes these yogurt makers would be like, wow, we had to throw out this gigantic, batch of yogurt because all the bacteria died.
Yeah.
And they couldn't ferment. It just rotted. So
what a waste. What a waste.
What a waste. But so if you've eaten commercial yogurt, it turns out you probably have swallowed a lot of CRISPR already in your life. So
that makes sense.
Yeah. But so some of these diseases may be edited out, and cystic fibrosis is probably the first up to really
they've already come up with DNA treatments for sickle cell as well.
Right. It wasn't everybody who got treated in that study got better. Yeah.
Yep. Every single person.
Super cool.
So.
Neat stuff. So, and personally, it gets kind of weird, but we have these embryos that then are affected with these different diseases, and and some of them that might be able to be edited out. So do we hang on to them or do we let them go? I don't know. It's one of those, it's kind of a strange
right.
world now.
Genetics as it is such an ethical quandary because there are so many sides to it. And as you alluded to earlier, there are a lot of people who feel like, messing with genetics is akin to playing God.
Right. Yeah. And, some of the, like, did you hear about that guy in China who edited
I think we talked about it the last time we met. Yeah.
Yeah. So super creepy. Because, I think what he was trying to do was say, oh, I'll do something that is so benign that no one could argue with it. So he, made those 2 embryos resistant to HIV.
Right.
But it turns out that there may be a bad thing to having that resistance to the HIV, having that gene modified may put you at higher risk for some sort of tumor formation or something.
Right. I think it was lymphoma or.
Yeah. So kind of crazy. So Tinkerbell. So some people are going to use this technology for no matter what we do, I think. But,
right. I mean, this is taking us back to Jurassic Park. Life finds a way. Diseases are going to find a way at some point, right?
Yeah. It's a strange deal.
Well, I guess thinking back to pregnancy, what happens when someone is already pregnant and comes in for screening. So then, we can offer a couple of different things then. So the most common OBGYN visit is someone who's come in and they have a missed period and they're already pregnant, and they're interested in some kind of genetic testing. So we have a lot of different modalities to test to see if there might be any chromosomal abnormalities present. Right now, the thing that's really in vogue is what we call non-invasive prenatal screening. So that's essentially taking cell-free DNA. So basically, as the pregnancy grows, the fetal placental unit starts to shed off some DNA. And it's floating in the mom's bloodstream. So it's just a simple blood test. And it can be done anytime after 10 weeks. Most companies say waiting like closer to 11, 12 weeks. And in obese patients, because they tend to have a smaller fetal fraction of DNA in their bloodstream, actually waiting even longer, just to avoid the no result possibility, which is not having enough DNA. And that is it's a good screening tool that's been widely adopted. And we've been using it a lot over at Banner.
Cool. How accurate is that?
So actually for Down syndrome, it is up to 99%.
Okay.
Yeah, it is quite accurate. But it's still considered a screening test, and it doesn't test for everything. So it can come back abnormal, or it can come back or a no result, but it doesn't tell you what that result might have been. So there's some NIPT screens, non-invasive prenatal screens, that are will show trisomy 21, trisomy 13, and trisomy 18, and some will actually show DeGeorge as well, which is a deletion on chromosome 22. But a lot of times when there's no results, we just don't really know what the issue is. So that's why it's still considered a screening test. So then comes the gold standard options, which are chorionic villus sampling and amniocentesis. Those are more likely to get you an accurate result, but there's really nothing that's going to tell you exactly what is going on until after birth or after termination, looking at the cells, looking at the karyotype of either a fetus or a neonate.
Right. Yeah.
That's the confirmatory testing.
Yeah, back in the day, we used, we were so afraid of, having a child. You see as an OB, you see all this mayhem, and so we did chorionic villus sampling because that was the technology at the time. And our oldest, who's transcervical, and then our youngest was the transabdominal. But boy, I tell you, ultrasound used to be pretty crummy, and I remember seeing that needle and pretty close to her head a couple of times, and I was like, "Oh, this is awful. Why'd I do this?" Yeah, but
ultrasound has come such a long way now, and it's actually people who aren't getting genetic testing either before pregnancy or in the early 10 to 15 weeks of pregnancy. A lot of times on their routine second trimester ultrasound, the one that people commonly know is the one where it's going to tell you the gender, they'll see something off with the lips or the nose, or maybe something a little off with the heart. And that's actually an indication to everyone should be offered genetic testing. But if you see something on ultrasound, that's another indication to offer genetic testing. And a lot of times we'll start with an NIPT. But some people will prefer to go actually straight for the amniocentesis because, as I alluded to earlier, that's the gold standard. And this all, gets us into the murky political area of, what are you going to do with that information if the amniocentesis comes back abnormal with something that's either incompatible with life or something that's going to produce a child with lifelong issues? What are you going to do with that information? Some people choose not to pursue an amniocentesis because they say it's not going to change anything for them. And some people say, this is something that I want to do because I might consider terminating this pregnancy.
Right. Yeah, we had a patient a few years ago who had, where they said high probability Downs. They didn't do the amniocentesis because they were like, we're going to have this baby no matter what.
Right.
And so they got everything all ready. They had all of their, they had the pediatric surgeons on notice in case, they had a duodenal problem or whatever. And then it was a normal baby.
Yeah. And that's the thing. That's the thing. It's 99%, but there's always going to be that 1% that it surprises you. So.
Yeah.
One of the reasons I decided to go into OB, and one of the reasons that I wanted to talk specifically about this topic, is when I was a medical student, the first rotation I did was in pediatrics, and the first surgery I ever saw was a crash C-section, and the baby had tanked, and as OBGYNs we see that strip and we're like, oh, we got to do something fast, and here I am, a lowly pediatric medical student, like, what am I doing? I guess I'm gonna catch the baby. That sounds great. And it turned out that the baby had an undiagnosed Down syndrome. It came out, and we all want our kids to come out screaming and kicking, and this one was a little bit duskier and a little bit floppier, and we found out it takes about 2 weeks for the karyotype to come back in most cases, and we found out later that it was trisomy 21.
Yeah. Boy, yeah, it's interesting. But are you happy you did OBGYN?
Absolutely, absolutely. For all the scary things, for all these crazy genes and diseases, and who knows what else, people playing God, people not playing God. I am so glad that I've done this with my life. It's been very, very gratifying, and I love being able to give women options with what they want to do.
Right.
Yeah.
It's a neat field. We get to do a little dabble in little bits of, well, a lot of surgery, a lot of other kind of stuff, other specialties don't get to do.
Right. And, being a generalist, you get that continuity. You can take care of someone from her first period to her first pregnancy or second pregnancy until, she is 50 years old and is like, I don't need this uterus anymore. And then you take her uterus out, and then next thing you know, her children are having kids, and you're still, for some reason, taking OB call and deciding. So it's that kind of continuity is it's few and far between, and it's really nice to be in a specialty where you get to not only give women options with what they want to do with their own bodies, but to be able to take care of them regardless of the choices that they make.
Right. Yeah.
And counsel them in the best way that we can with the information we have.
And I think it's such a cool specialty too, because people can be really on the, like with preeclampsia, like, boy, you can be a death's door, but then you're going to come all the way back most of the time without any sequelae. And that's just super, super gratifying,
Yeah, absolutely. Yeah. Absolutely. So, and then it also allows us to make friends with super specialists like you, Dr. Hutchison.
Anyway, what other things should we talk about as far as genetics? Do you think there's any other
I feel like we covered a pretty broad range from preconception to post-conception. But one thing that I think is important for generalists to know is that the carrier screening can often show things that could affect the mom. So it's not just in terms of what you might pass along to a fetus. It could be how you are affected later on in life. So a lot of these panethnic carrier screenings are also looking for Braca. They're looking for Huntington's, things like that. So these are adult onset diseases that might not manifest, and maybe you didn't know who your father was, you were adopted, something like that. So you don't know that this is a gene that might run in your family and could affect you later on in life. And it could alter your reproductive choices. Right.
So talk a little bit about the Braca stuff. Explain what the Braca is.
Right. So there's Braca 1 and 2, and they're commonly known as the breast and ovarian cancer genes. It increases, having one or the other can increase your risk of getting breast and ovarian cancer from anywhere from 30 to 80%. The most common in both being breast cancer. One sort of bright side of having Braca is that the breast cancers and ovarian cancers that people tend to develop tend to be more susceptible to treatments that are out there, but it's still, both of them can be devastating diseases, and both of them in fact are autosomal dominant. So you only need one bad copy to manifest the gene. Now it's something that might not show up in it's something that might not show up, but it's something that might show up in the carrier screening. So you come in for a preconception visit, or you come in when you're pregnant, you decide to do this expanded carrier panel, and that is what shows up. So it might not immediately affect your fetus, but it might affect you and in the choices that you make in the future.
Sure. Yeah. So talk about what you can choose to do if you've got one of those Braca genes.
Right. So what if someone is positive for a Braca gene or any kind of genetic disorder, then we send them for a genetic counseling visit. We also send them to a GYN oncologist and a breast surgeon to see what their options are. The GYN oncologists will often, once they're done with childbearing, once they're 40 or 10 years before their mother, if their mother developed an ovarian cancer, will suggest a risk-reducing salpingo-oophorectomy, which is taking out the tubes in the ovaries. There was a study that linked BRCA1 to endometrial cancer. So some people are doing hysterectomies with BRCA1, but it's not sort of definitive. Yeah. And then in terms of the risk for breast cancer, with both BRCA1 and BRCA2, we'll send them to a breast surgeon for an evaluation, and they'll do serial imaging. They'll get mammograms and MRIs, usually alternating every 6 months. So they're getting some kind of imaging, and then they'll usually recommend a prophylactic mastectomy, which is to say that you have the breast tissue surgically removed, and they'll send it to pathology, see if there's anything unusual, and then they'll still continue surveilling the breasts every 6 months just to be sure. And it's always important to get a breast exam, even if you're not BRCA1 or 2 positive, and then kind of go from there.
Yeah. I had a patient in here the other day whose mom was BRCA positive, BRCA2. And a big family, and half the girls had it, half the girls didn't, just like you would expect. So
if we're taking it back to sort of Mendelian genetics, autosomal dominant, you look at the little phenotypes and the pedigrees, and you'll see the little circles that are filled in, and those are always kinds of test questions. Pedigree and decide how the gene is passed on.
Yeah. So now we're recommending that if anybody has a relative, even if like an aunt or uncle or whatever, over 50 with a history of breast, ovarian, colon, prostate, or endometrial, that they get the Myriad screen. Yeah, which tests for all these tumor markers, and they keep adding new ones. It seems like every year. So.
There's Lynch syndrome. There's Braca. There's all kinds. So.
Yeah, but if you can get out ahead of it and keep yourself from getting into trouble, it's a great thing.
And it increases the surveillance. But like I alluded to earlier, even with preconception counseling, you have to decide what you're going to do with that information and how it's going to. Some people don't want to know, and some people do want to know and will take action with it, and some people would prefer not to. And I think that's the crux of genetic testing in, whether it's for reproductive planning or whether it's for your own health and wellness. It's always a choice whether or not you're going to do it or not.
Right. So. Yeah, you're not at gunpoint. You can kind of pick your own thing. Right. Yeah, for some people it's a little weird. And even for embryos, like when we screen embryos, we're screening embryos because we know that at 35, that's kind of the break point where you're going to get way more abnormal eggs more abnormal eggs than normal. So we'll recommend that or offer it. Most people will do it after 35, and we think it's probably 99% as well. But we've had 2 now where the testing was wrong, and one of them was a normal embryo we had transferred, and it turned out to be an abnormal embryo on the NIPT, which was then confirmed. And then the other was the wrong gender.
Oh, surprising.
But they're not unhappy, but they were, but that's sort of an odd thing to see.
Right, right. And that's the thing. There's always going to be some degree of lab error, as
Right.
strictly protocoled as all of these things are. There's always going to be some possibility, some room for error, and so that's also something that you have to take into account when considering undergoing any kind of genetic testing.
Yeah.
And then there's always the possibility of mosaicism, and now we're getting real deep into science, but not all of our cell types are going to have the same DNA.
No.
That's some of your cells might be positive for what's called Turner syndrome, XO, and some of your other cells will be, just XX. So
yeah, well, years ago, I shared this really nice patient with Jim Machula, who's this fantastic OB, and you probably remember Jim.
Yeah, he's lore at Legend and Lore at Banner.
Yeah, he just had a kind of a sixth sense sometimes about things, and so he ordered a karyotype on this gal, and and it came back, she was mosaic Downs.
Well, look at that.
Normal intelligence, normal height. I mean, she didn't have any other features. And I'm like, why did you order that karyotype? He's like, I have no idea. I just thought there's something that's a little off.
Right.
Yeah, mosaicism, we see that, on the original embryo screenings, that technology, there was a thing called microarray that came out and was probably the first that was widely used. And also in the IVF laboratories, the culture technique led to a lot of embryo mosaicism. So we know that normal human embryo mosaicism is like maybe 1% to 2%. And really in an IVF laboratory, that's what we should see as well. We should see somewhere around 2% or so, or less. And luckily that's what we're seeing now with the newer screening, which is called next generation screening. But then the big question is, what do you do with those mosaic embryos? And using the older technique, the people were getting lots and lots of mosaic embryos, like 16% or 20%, and they were taking those. And so a lot of these practices back east were taking those embryos in groups of, say, 3 or 4 or 5, and transferring them. And they actually were getting reasonable pregnancy rates. And then, the big question is, how is that going to affect the baby down the road? Yeah. Like, and it really may not. The mosaicism that you're picking up in the outer part of the cells, what's going to be the placenta, may not affect the inner cell mass, because the inner cell mass is not as tolerant, apparently, of mosaicism. But that being said, there have been a couple of studies now where they've taken discarded embryos that are mosaics, and then they've rebiopsied, and those embryos are truly abnormal with the newer screening. Yeah. In most of those studies. So I would not transfer a mosaic embryo. Yeah. On the newer stuff.
Yeah.
Well, very good. Well, thank you very much.
Of course. Happy to be here. Happy to do this.
Yeah. So Dr. Aleena Lakhanpal, she's at Banner UMC. She is fantastic. She has an extremely good fund of knowledge. She's very good technically and very kind, as you can see. The main number, 694-6101.
6010.
6010. There you go. Very good.
Impressive that you remembered it.
Yeah. Well, thanks for being here. And if you came in late on it and you want to go back and look at it again, it'll be on our website. So right. Thank you, Dr. Lakhanpal. I greatly appreciate it.
Yeah. Great.
Have a great night.
Yeah, you too. Bye.
Bye-bye.